Common Variable Immunodeficiency, CVID. Number 1. Introduction. The immune system plays a vital role in defending the body against infections and maintaining overall health. Primary immunodeficiency disorders are conditions in which part of the body's immune system is missing or does not function properly. Among these, Common Variable Immunodeficiency, CVID, is one of the most frequently diagnosed symptomatic disorders. CVID is characterized by reduced levels of serum immunoglobulins and impaired antibody responses, leading to recurrent infections, autoimmune complications, and an increased risk of malignancies. Because its symptoms are diverse and nonspecific, CVID is often underrecognized, resulting in delayed diagnosis and treatment. Understanding CVID in detail is crucial for improving outcomes, as early intervention can reduce complications and enhance quality of life. Number 2. Definition. CVID is defined as a primary immunodeficiency disorder characterized by low levels of at least 2 immunoglobulin isotypes, commonly IgG and IgA, with or without low IgM, accompanied by poor or absent antibody responses to vaccination or natural infections. Patients with CVID present with recurrent bacterial infections, autoimmune manifestations, chronic lung disease, gastrointestinal disturbances, and in some cases, malignancies. 3. Etymology. The term common variable immunodeficiency was introduced to describe both the frequency and variability of the condition. Common. It is one of the most prevalent forms of clinically significant primary immunodeficiency. Variable. Clinical manifestations differ widely among individuals, ranging from recurrent respiratory infections to autoimmune disorders or malignancies. Immunodeficiency refers to the weakened immune system function caused by defective antibody production. Number 4. Epidemiology. CVID affects approximately 1 in 25,000 to 50,000 individuals worldwide, making it the most common symptomatic primary antibody deficiency. The condition affects both men and women equally, with no clear sex predominance. Although CVID can occur at any age, it is most frequently diagnosed in young adulthood, 20 to 40 years. Delayed diagnosis is common, with many patients experiencing years of recurrent infections before receiving proper treatment. Prevalence is higher in populations of European descent compared to other ethnic groups. Number 5. CVID is a heterogeneous condition, and researchers have proposed subclassifications based on clinical and immunological characteristics. Major phenotypes include 1. Infectious phenotype, recurrent bacterial infections, especially of the respiratory tract. 2. Autoimmune phenotype, autoimmune cytopenias, thyroiditis, and rheumatoid arthritis. 3. Lymphoproliferative phenotype, persistent lymphadenopathy, splenomegaly, and granulomatous disease. 4. Malignancy-associated phenotype, increased risk of lymphoma, gastric carcinoma, and other cancers. Number 6. Causes. The exact cause of CVID remains unclear. Unlike some primary immunodeficiencies, CVID does not usually follow simple Mendelian inheritance. Instead, it is thought to result from a combination of genetic predispositions and environmental triggers. Several gene mutations have been associated with CVID, including TNFRSF30B, TACI, ICOS, BAFR, CD19, CD81, and others, which affect B-cell signaling, differentiation, and antibody production. Environmental factors such as chronic infections or immune dysregulation may also influence disease onset. Risk factors. Risk factors associated with CVID include family history of primary immunodeficiency, genetic susceptibility, particularly mutations in immune-related genes, consanguinity in some populations, increasing the risk of genetic disorders, environmental triggers, such as chronic viral or bacterial infections, which may exacerbate immune dysfunction. 8. Complications. If untreated, CVID can lead to serious and potentially life-threatening complications. Respiratory complications. Recurrent pneumonia and bronchitis may progress to bronchiectasis and chronic lung disease. Autoimmune disorders. Autoimmune cytopenias, anemia, thrombocytopenia, neutropenia, thyroiditis, and arthritis. Gastrointestinal manifestations. Chronic diarrhea, malabsorption, weight loss, and inflammatory bowel disease-like conditions. Lymphoproliferative disease, persistent lymphadenopathy, and splenomegaly. Malignancies, notably non-Hodgkin's lymphoma and gastric carcinoma, which occur more frequently in CVID patients than in the general population. Number 9. Pathophysiology. The underlying defect in CVID is a failure of B lymphocytes to differentiate into plasma cells. resulting in an insufficient antibody production. Although B cells are present in normal or near normal numbers, their function is impaired. T cell signaling abnormalities, defective cytokine responses, and impaired interaction between B and T cells also play a role in disease development. Consequently, patients are unable to mount effective immune responses to pathogens or vaccines. The immune dysregulation also predisposes to autoimmunity and malignancy. 10. Signs and symptoms. The clinical presentation of CVID is highly variable. Common signs and symptoms include recurrent respiratory infections, sinusitis, otitis media, pneumonia, bronchitis, chronic cough, wheezing, and progressive lung damage. Gastrointestinal symptoms, diarrhea, malabsorption, abdominal pain, fatigue, fever, weight loss, and recurrent systemic infections, lymphadenopathy, and splenomegaly. Autoimmune manifestations, such as hemolytic anemia and idiopathic thrombocytopenia. Increased susceptibility to malignancy. Number 11, medical diagnosis. Diagnosis of CVID requires both laboratory and clinical evaluation. Laboratory findings, low IgG with reduced IgA and/or IgM, poor antibody response to vaccines. Flow cytometry, normal or reduced B cell numbers, abnormal memory B cell populations. Exclusion of secondary causes, such as HIV infection, nephrotic syndrome, or malignancy. Imaging studies. CT scans may show bronchiectasis or lung damage. Abdominal ultrasound may reveal splenomegaly. 12. Nursing diagnosis. From a nursing perspective, the following diagnoses are common. Risk for infection related to immune deficiency. Ineffective airway clearance related to chronic respiratory infections. Imbalanced nutrition, less than body requirements due to chronic diarrhea and malabsorption. Activity intolerance and fatigue related to recurrent illness. Anxiety, fear, or hopelessness related to chronic disease and uncertain prognosis. Number 13. Medical management. Medical management of CVI is lifelong and focuses on preventing infections, reducing autoimmune complications, and monitoring for malignancies. Immunoglobulin replacement therapy, IVIG or SCIG, is the standard of care and significantly reduces infection frequency. Antibiotic therapy, prophylactic or therapeutic to treat infections. Immunosuppressive drugs such as corticosteroids for autoimmune complications. Cancer surveillance through regular screening. Vaccination. Inactivated vaccines may be given, but live vaccines are contraindicated. 14. Nursing management. Nursing care is centered on infection prevention, patient education, and emotional support. Key interventions include monitoring for early signs of infection and initiating prompt treatment, educating patients and families about adherence to immunoglobulin therapy, supporting airway clearance through hydration, chest physiotherapy, and breathing exercises, providing dietary advice and monitoring for malabsorption, offering psychosocial support and counseling to improve coping skills, encouraging avoidance of infection sources, and maintaining hygiene practices. Number 15, treatment options. Immunoglobulin replacement therapy, lifelong, either IVIG or CIG, antibiotics for acute infections and prophylaxis, immunosuppressive therapy for autoimmune disease management, hematopoietic stem cell transplantation, HSCT, in rare, severe, or refractory cases, still under research. Number 16, psychosocial interventions. Living with a chronic condition like CVID can have significant psychological and social impacts. 5 key interventions include 1. Patient and family education, improving disease understanding and treatment adherence. 2. Support groups, connecting with others experiencing similar challenges. 3. Counseling or psychotherapy, managing anxiety, depression, and coping with chronic illness. 4. Lifestyle modification support, guidance on stress management, exercise, and nutrition. 5. Educational workplace assistance, helping patients balance medical needs with school or career responsibilities. Number 17, prevention. As CVID is a genetic primary immunodeficiency, there is currently no way to prevent its occurrence. However, early diagnosis and timely initiation of immunoglobulin therapy can prevent long-term complications. Patients should also avoid unnecessary exposure to infections, adhere to regular medical checkups, and undergo routine cancer surveillance. 18. Conclusion. CVID is a heterogeneous and complex disorder that represents one of the most common symptomatic primary immunodeficiencies. Its hallmark is impaired antibody production, leading to recurrent infections, autoimmune manifestations, and an increased risk of malignancy. Although the exact cause remains unknown, advances in immunogenetics have identified several associated mutations. The cornerstone of treatment remains lifelong immunoglobulin replacement therapy, supported by antibiotics, immunosuppressive therapy for autoimmunity, and routine monitoring for complications. With comprehensive medical, nursing, and psychosocial care, patients with CVID can achieve improved outcomes and a better quality of life despite the chronic nature of their condition. Thank you. Have a nice day.